certainly.
Okay. And just to follow up on that, that would, to your knowledge, that is below the national average. Would that be correct? Fair statement?
I don't have a comparison or compared to the national average.
Okay. All right. Let me move on to another question or so. Just thinking about the dental for a moment, and I'm not taking these questions in any particular order that you had on slide 9. And maybe this is just an observation on my part, but we have seen growth. You were showing growth there in recipients, and yet an actual decrease in historic expenditures and the average monthly cost per recipient. But that is, those dental services are being provided in a fee-for-service environment, are they not?
Yes, they are.
Okay. Another question I have with respect to skilled nursing. You talked about the upcoming case mix freeze, but having an effect there. We've seen a fairly stable, basically I think because we've got fairly stable beds. Because you have CON control beds, which have been a freeze on, you have a rate. Are you aware of how the skilled nursing daily rate compares in North Carolina to a host of other states, whether it be the Southeast or the South or nationally? It's my understanding it's a fairly low rate in North Carolina.
Representative Dollar, I'll try to answer that question. Yes, we have seen a fairly stable rate in nursing homes, both beds and in census in the past 2 years. We pay our nursing homes per diem based on a fair rental value, which is a model used both in Virginia and in West Virginia. But as far as how our actual per diem today compares to those other states or any of the Southeast states, I don't have that data in front of me. We can certainly get it.
Okay. And to your knowledge, just following up on that, you don't necessarily know when the last time there was an actual increase in the rate being paid, do you?
Outside of the normal case mix adjustments, typically the nursing home have a case mix adjustment on a quarter basis that will continue through January 1 of 15, in which it'll freeze. We did have a slight increase, I want to say a couple of years ago, when they increased the tax. The nursing homes do pay the bed assessment at 6%, they are at the cap at 6%. And so when we raised that at 0.5%, they did get a slight increase in the rate to cover the assessment they were being paid, or that they were paying.
But outside of that, you're not aware of any rate increase?
It has been a few years since we've had rate increases with all of our rates.
I think that's a great point to make. Let me ask you a different question. Mr. Denley, back on, I guess it's slide 7, and this is sort of more of a, I'll make it in the form of a personal request. I'll say it like that. Because I think sometimes, because you mentioned this in your verbal comments, but it doesn't show on the tables, and that is the fact that rebates are there, and I know it's been sort of an ongoing discussion in various and sundry times, how rebates are treated. Because I know that some folks say, hey, look, that's a receipt in, and we sort of handle it over here, and we handle the cost over here, but they are related. I mean, they are absolutely related, and I think that and maybe this is just a request going forward, I think it's, in my view, it's always good to have the amount of rebates in the graphs when you're looking at it year over year. That way people can understand that there's a connection, because sometimes people think, oh, well, we'll just cut this in half and we'll save X amount of money, It's like, no, you're also costing yourself on the, and those rebates have changed and they're very important, obviously. So I don't know if you want to comment on that or not.
Yeah, that's a very good point. Look, the rebates for this year were $725 million. That could be a business in and of itself. And because of that, and that really goes back to some of the processes that we've been built in, it used to be that we would do the billing of those rebates, and then we would sit back and they would collect those over time. We have instituted a new procedure now, and that is what we're calling dialing for dollars, where we are being thrown in the side of labelers. We are contacting them as when those bills go out. When we want to make sure, because that dollar is so important to DMA's overall spend on a net basis, we have instituted a process where we will now start looking to recover those. Unfortunately, from a penalty standpoint, CMS imposes that the cost of any penalty, it's not like a linking of a credit card, the cost of that is just a 3-month T-bill. And with 3-month T-bill, I think it maybe 20 bits. There's no real true financial penalty associated with that, and that's why it's important that we make the noise, and that's why it's important that we institute the process and make sure we recover our dollars on a timely basis.
Thank you, Mr. Chairman. Just a brief comment. I think that when folks focus on both the information and the type of information that's on page 3 or slide 3, and then particularly focus on slide 4, where we were $600 million. I actually think it might have been more than that, but be that as it may, moving from a $600 million hole to a $63 million in the black to the good is simply phenomenal. And I just think that the leadership of this committee, the appropriations committees, and the Senate and the House and the Department over the last almost 2 years to be congratulated on the tremendous progress, because a lot of states are not haven't made this kind of progress that we've been able to make digging out of some extremely difficult positions over the last several years. And I think it's great, and obviously as an appropriator, as some of the other appropriations people here, we want you to continue with that trend. That's the line we want to see followed for the future. So thank you all very much for all your efforts.
Representative Lambeth. Thank you, Mr. Chairman. You know, in North Carolina, we've been criticized by some for not expanding Medicaid. Yet at the same time, we've actually been expanding the benefits within the Medicaid program over the last 20 years fairly substantially. You know, we're one of the most generous states in terms of benefits and eligibility requirements. Do you have any professional judgment or estimate of how much you think we pay in North Carolina for those additional optional services when we're competing with our colleagues around the South, Southeast, for lots of other things, for improvements in education, for new employers to relocate here, that we're actually investing in Medicaid that they're not? You have some kind of, is it 5%, 10% more that we pay here because of these extra benefits? Do you have any estimate of that?
I do not, but if you want, we could try to do some comparing and some tracking and see how North Carolina is doing compared to other states.
Senator Tarr.
Thank you, Mr. Chair. First question, if we go jump to page 8, and this is just picking up really on Representative Dollar's conversation on the SNFs, just what's the thought behind freezing the case mix index, other than kind of locking down the cost?
Well, I think, Senator Todd, this year in the legislation, we were directed to lock down or to freeze the case mix index. The thought, I believe, is to, like the others, remove inflation. This would, the thought is to remove inflation from their rate.
Thank you. One follow-up. On the model for budget forecasting model, are you guys able to do that at a CPT HCPEX level?
Not sure what that is.
We do collect the CPT HCPEX data on many of the claims. There are some claims that we don't have all of it, institutional claims for one, but you know, it is in the realm of feasible. Don't know if it's how possible it would be within the near future.
And this has just been a comment picking up on Senator Heise's comment, because that would give us the most granularity, give us the most information. We capture it anyway on all the claims, or a majority of them. But if we're building it on that on ICD-9 codes, you're looking at 10,000 codes, you're looking at 100,000 providers, you're looking at 1.5 million enrollees. Excel, if I recall, was recently expanded, could only handle 1 million calculations at a time through their macros and pivot tables, and if that's the case, Excel will be extremely limited in its performance handling volumes. So that's just something we need to, I would think we would want to investigate, depending on the level of detail and granularity we're looking at, to be able to actually model the degree of, again, specificity at a CPT level, which would help improve the accuracy.
Yes, and that's a good point, but again, what we're looking to do is just get to the first foundation, is get to from where they are to, and continue to build. I mean, we have met with insurance companies in the state as to what they do, and it's impressive at the level that they have. I mean, we have met with various companies and the level of number of actuaries that they have. They have 25 in some instances that could do that level of analytical type work. We're not there yet. We're just trying to walk. We're just trying to get to the foundation, but your point is very well taken.
And then one last follow-up. Since you bring up the actuarial statistical viability or accuracy of those numbers, are we looking for bringing that skill set to work with us in the model as well, or not yet?
Not yet. I mean, as Mark Ogle had mentioned, we're looking to hire 2 actuaries, and if they have that level of competency, well, it's one of the things that we're going to look to use them for. So that's a very important point to note. But when we do our own analysis, we're also going to be doing considerable QCing on our model. So we're going to probably be reaching out to sources within A&M, outside of A&M, who could take a look and make sure that what we're doing is correct.
All right, if there are no additional questions on this topic, we'll move on. Thank you, gentlemen. This time we'll move on to the NC-FAST update and start with Mr. Cooper.
Representative Burr, co-chairs and members of the Oversight Committee. Good afternoon. I'm Joe Cooper, Chief Information Officer of HHS. I joined HHS in February of 2013. Prior to that, I spent 35 years in the financial services sector and a variety of different executive roles. I'd like to thank you for the opportunity to bring you up to date on NC-FAST, the system used by counties across the state to support many of the social service programs, including FNS, better known as food stamps, and Medicaid eligibility. Because the story of NC-FAST is inextricably tied with FNS and Medicaid, I've asked several of my DHH colleagues to join me today. First is Angela Taylor, who serves as the NC-FAST Director. She'll focus on the project status, past, present, and future. And we have Wayne Black, who directs the Division of Social Services, to explain the FNS or food stamps program. And finally, we'll hear from Sheila Class from the Division of Medicaid Assistance to explain Medicaid eligibility and how changing criteria mostly brought about by the Affordable Care Act has presented us with challenges, and challenges that we are successfully meeting. As many of you have heard me say in the past, NC-FAST initiative is 10% technology and 90% change management. The counties and HHS have successfully managed through a mountain of change over the last couple of years. Much of the change was driven by implementation of the Affordable Care Act. The county workers are on the front lines every day serving the needs of our citizens. It's through our collaboration with the counties that we've already successfully met specific goals earlier this year, and we're on track to achieve other defined goals later this year. Mr. Chair, with your permission, I would like to ask Angela Taylor, Director of NC-FAST, to provide us a project update on NC-FAST.
Ms. Taylor?
Good afternoon. I'm Angela Taylor. As Joe said, I am the Director of NC-FAST. I've been in IT for 26 years, and 25 of those have been with the state. So I've been very involved with a lot of these systems that we are currently trying to replace as part of NC Fast. So with that, just reminding everybody that, you know, NC Fast, its name kind of tells the story that it is NC families accessing services through technology. So I think it's important to start with that and show, as you can see on the screen, that these are the programs that are in focus and scope of that initiative. What we're trying to do is implement a software solution that will deliver these benefits and services that are listed here. The key thing, as Joe said, is it is very important to understand that it is 10% technology, 90% business process change to our 100 counties of social services. The goal is to also replace 19 legacy systems that we currently have within the department that in some way or form support these programs listed here. So moving forward, we want to make sure that we're providing our counties with a lot of the support that we have learned over the start of the implementation. Key things to understand is we are a program